Welcome to all to another installment of Journal Clubs based on articles appearing in the journal Gastroenterology. Today, we're very fortunate to have Giovanni Marchegiani from the University of Padua to talk about an important paper of his that appeared in Gastroenterology Online in July of 2023 and then in the print version in October of that same year. The title of this important paper is Surveillance for Presumed Branch Duct IPMNs of the Pancreas, Stability, Size, and Age Identify Targets for Discontinuation. We're lucky enough to have Dr. Marchegiani to present the paper, and we have the GI training program at Northwell in New York. A large number of trainees have chosen to join us. They have a series of questions. We hope that the next 45 minutes or so will be useful to all. Giovanni, please.
Thank you very much, David, for the terrific opportunity of being here today. And I would like to extend my gratitude for everyone being connected and watch this episode. So as David said, the focus today is going to be on the surveillance for presumed BD-IPMN of the pancreas. And in particular, the main topic would be regarding follow-up discontinuation, which turned out to be probably one of the hottest topics also in the newest international guidelines that have just been released after this paper. So I'm going to try to convince you that this topic is really relevant in the next 3 slides with basically 3 facts. The first one is that asymptomatic pancreatic cystic neoplasm are extremely common. And basically, the more we scan the general population, the more we find cysts in the pancreas. So basically, the incidence is growing as much as we're scanning the general population. Fact number 2, as a consequence, we saw a shift in our management towards this entity as we were more aggressive back in the day, be more proactive to surgery, whilst at the present time, the vast majority, if not all, the small branch duct IPMN, they are enrolled into a surveillance program. However, still, there is no clear consensus about the possible surveillance discontinuation. So once this entity, at least, after a matter of time, they remain stable, what to do? Well, according to the international guidelines, we have this, I would say, hazy concept of fitness for surgery, which still actually reflects the need in many cases of a lifelong surveillance, with relevant implication, last but not least, also from the psychological standpoint, as most of these patients, they feel they have like a Damocles sword on their head. However, the AGA guidelines, the one released more than a decade ago for the first time, tackled the issue of stopping surveillance after 5 years of no change in the cyst. But at that time, when they were first released, the level of evidence was actually very low. So we started to tackle this issue by possibly identifying a population at a very low risk of malignant degeneration. And we gave to this entity a name, trivial IPMN. And with this concept, we want to basically identify those lesions not really changing year after year and remaining stable after the threshold of 5 years, because we wanted to mimic the original publication from the AGA guidelines. And what I'm presenting you today is the validation of this first report, as you can see here, on a largest cohort of patients either from the West and from the East. And in this analysis, we wanted to assess whether these cysts conveyed a higher risk of harboring malignancy than the general population. So we needed to consider the standardized incidence ratio using country and sex-specific crude rates, defining that as a total number of observed cases in the study cohort on the total number of expected cases in the cohort of study. And that's what we did. First of all, we wanted to assess whether the overall population of BD-IPN were at risk of developing features of malignancy, which was the case, you see here, both in terms of worrisome feature and high-risk stigmata, and also the population of trivial BD-IPMN after 5 years, they sometimes develop worrisome feature, as you can see here, after 5 years, and even high-risk stigmata, because the risk that every entity might eventually evolve during time will never be zero. But, and that's the most important table of this short presentation, whilst the overall risk of the population to harbor a cyst conveying a higher risk than the general population is actually higher, if we call out the trivial IPMN on patients above the threshold of 75 years, so once again, the cyst is stable for 5 years and the patient is now 75, the risk is not higher than the age-matched control. And the same concept holds true if we sub-identify the very small one, probably not even IPMN, so smaller than 15 millimeters, with a threshold of only 65 years old of age. And if you're not still convinced about the need to stop surveillance in these cases, but just keep in mind that the standardized incidence of ratio for pancreatic cancer and chronic pancreatitis is actually 20-fold higher than that of trivial BD-IPMN. And as a surgeon, I would never actually even think about prophylactic surgery in patients with chronic pancreatitis. So to conclude, this is my last slide. We think we have identified a subset of population relevant also for our healthcare system that, as you can see, after 5 years of surveillance without developing any worrisome feature or high-risk stigmata, might be target for follow-up discontinuation. If the cyst is below 3 centimeters, 75 years old, but if the cyst is very small and no changes occur, the patient can be 65 and eligible to follow-up discontinuation. Thank you very much for your attention.
Thank you, Giovanni. In a very short period of time, I think our colleague has done a very nice job of encapsulating the tension at the middle of this issue. Older patients are the patients who get pancreatic cysts. The overwhelming majority of these cysts will never turn into cancer. Nonetheless, many of them will change in some ways over time that appropriately raises the concern that patients and their doctors have. So many patients go to surgery, but even in the hands of the best surgeons, the mortality associated with a large pancreatic operation is on the order of 2% or so within 30 days. And morbidity, serious morbidity, is about 30%. No one wants to expose patients to that risk unless you're convinced that the risk of not treating them is considerably larger. And as Giovanni suggested, there is an ongoing debate about who the most appropriate patients for surgery are, who should stay in surveillance and for how long. There was an update of one group of international guidelines, initially called Sendai and then called Fukuoka and now called Kyoto, which attempts to look at this. And to the credit of Giovanni and his team, the Kyoto guidelines now actually explicitly talk about how long patients should be surveyed for, which when that idea was suggested by the AGA guidelines 10 years ago, if anything, the most controversial part of the AGA guidelines then was the idea that you could stop surveying people. So with all of that as an introduction, let me turn this over to Dr. Bukobo and his Northwell team, who have prepared a series of interesting questions for our speaker.
Excellent. Thank you, David. And thank you, Giovanni, for a wonderful presentation and congratulations on such an important paper and relevant topic. Our fellows have presented several questions for you today. And with that, I'm going to turn it over to our first question that comes from our fellow Alexa.
Thank you. Thank you for this kind of just presentation and overall paper. I think you do raise a really good point that it has psychological impact on patients. I have a young patient who is, immediately when I put the word pancreas and either risk of cancer or just the word cancer in a sentence, it puts up this fight or flight response for patients. So I think research in this is really important. So thank you for that. So with that said, my question is, since many of the centers had different radiologists, so different radiologists were used to assess imaging and different imaging modalities were used, was there a way that you controlled for the margins of error in size calculation and actual diagnosis of these IPMNs? Or do you think that these margins were trivial?
Thank you for the question, Alex. I think you touched a very good point. So, as you know, when these multicentric studies are set together, I mean, the risk of bias is always there. I think that in this analysis, we wanted to be a little bit, let's say, more gross in this sense, because of course we were very cautious when a cyst was developing either a worrisome feature or high-risk stigmata. But at the same time, when it came to, size of the cyst, we really wanted to, be clear cut either above or below 3 centimeters or 15 millimeters. The only features that we cared about was the growth rate. So only cysts that underwent proper follow-up according to the guidelines were included in the study. So this was done to reduce the bias. So again, I think that the message here is that once you assess stability, so once the cyst is not really changing over time, then you might consider that as a candidate for such new policies, because as you said, I mean, it has, well, many implications. We touched a little bit the issue of the cost, but I think the one related to the psychological well-being of our patient, that is probably even more important. And so, yes, so the radiology was a key point. We actually included cyst followed either with MRI, which is very popular with MRCP in Europe, but also CT scan, which is probably a little bit more popular in the US, and of course endoscopic ultrasound when the guidelines were in favor of this modality. So probably in this way we overcame the practical issue of having, of course, the different radiologists. But we always actually look at the CT scan and the actual imaging to be sure that no additional features were present.
Right. That's what I was wondering if, it was just you taking the report or taking the word saying diagnosis of this, and then, or if there was actual review of imaging. So
problem with if I could comment on that, problem with the report, at least in Europe, is that there is not a standardized fashion to report this cyst. So probably this is one of the factors that still plays a major role in needing to see the actual scan. Probably as this is truly a from the epidemiological standpoint a very relevant issue. One of the policy that we could incorporate in new guidelines could be that the need to have a standardized report so that at least some features are always described by a radiologist. This might introduce probably, a way to reduce the bias. But so far, I would like to hear also other comments, but we don't really rely on the report itself.
Thank you.
That's a really interesting point then. And in our practice also, we'll typically take a look at the scans ourselves and make assessments based on what we see. Along those lines, and I don't see if Michael's on the line, but he had an interesting question that segues well with this. Mike, if you are on, mute yourself, but if not, I'll go ahead with your question. But the question is...
I'm here, Dr.
Oh, good. Excellent. I wasn't sure who iPhone was. Thanks, Mike. Go ahead.
Okay. Good morning. Thank you for being here to discuss this interesting topic. So my question is, were the worrisome features or the high-risk stigmata included in the study, were these the same or different among the different studies involved, or did all of the countries follow the same criteria as listed in the IAP guidelines?
Thank you for the question once again. No, so we for reliability, we ask centers to define the presence of either worrisome feature or high-risk stigmata according to the international guidelines. David was pointing out that sometimes it's confusing, to keep up with all the new updates, which in a way is great because we have an excuse to travel to Japan every 2-3 years. But no, I mean, it's actually a very good point that you touched. And for reliability, we use those guidelines, even though the European guidelines, which are also very popular in Europe, they define basically the same features, but with different words. So they're defined as relative or absolute indication for surgery, but they basically mimic the worrisome feature and high-risk stigmata that were used for the study.
Thank you for that. So our next question comes from Ninu. Can you unmute yourself, please?
Yeah, sure. First of all, thank you so much, Dr. Weinberg, Dr. Moiti. How are you? Thank you for being here. Appreciate it. But I had a question about the article talks about the healthcare costs. I was wondering, is there like an approximate cost that you're aware of for the surveillance of these cysts? And like, how often do patients older than 75 years actually get tested for these? Let's say they're like functional. Like, what would be your approach?
Well, thank you for the question. This is absolutely, one of the major, well, we hope, well, consequences of paper like this. So we didn't really dig in a cost analysis because, as you might expect, we dealt with very different, systems, across the oceans. And also the way these examinations are reimbursed is completely different, depending whether it's in the US, different policies and insurances, things like that. So I can tell you how in Europe it looks like. So in countries like European countries where the public healthcare is, well, it's actually public, and the patient, they don't pay for the examination, but we can expect that, for the regular follow-up after 5 years, we're talking about either an MRI with MRCP or a CT scan every 6 months or 1 year. In case of no change now, the new Kyoto guidelines actually extend the follow-up up to 18 months. So in this way, probably there is also, you can see a sort of a way to reduce the cost. But at the same time, the numbers we're talking about are huge. So there is a new paper published on JAMA from the Mayo Clinic group, attesting an incidence of around 15% above the age of 70. So we're clearly talking here about millions of possible cases. So probably the next, papers should focus also on cost. So what is practically, the saving in terms of examination that are not performed thanks to this policy, but still, this was not, the main topic of the current analysis. Even though, of course, we really, in the discussion, we pointed out that there is a strong interest in the healthcare system in reducing the costs relating to this examination.
Let me jump in briefly. The cost issue is an important one, and the answers are limited. There was a modeling study done at the University of Virginia in 2020 or so. Granted, it had all the problems that modeling studies have, where you have to believe all the assumptions are correct. But even if the scale is generally right, the cost to find one cancer following the Fukuoka guidelines, which are not terribly different than Kyoto, so it's probably not worth talking about it at length. The cost to find one cancer was $1.4 million. So we're talking about spending an awful lot of money. Now, how much you can reduce that by fewer imaging studies, less, or I should put it this way, more precise risk stratification tools to identify who should go to surgery, that number can almost certainly be whittled down. But like anything else, where the prevalence in the population of pancreatic cancers that will arise out of a cyst, the numerator in that calculation is very small compared to the denominator. So the cost to find even a single case will be substantial. Now, the counter argument is pancreatic cancer is a terrible disease. And as we've hinted, if you've got this lesion, a cyst that might put people at risk, to tell patients, hey, it's going to cost a lot of money to find your cancer, we're not going to do it at the population level, is untenable. So how to solve this cost problem, as Giovanni points out, it's not a point of his paper, but his paper and others like it continue to point up the need to figure out how we're going to pay for this. So back to you, Juan Carlos.
And paving that way to lowering that burden on healthcare is so important, and hopefully we'll find additional markers and studies like this that'll help us answer those questions. So, Jack, you had a question on biomarkers, if you could.
Yeah, thank you for discussing this important study that really has a practical impact on kind of my day-to-day practice. But I guess my question was there any, I know there have been some studies recently looking at specific biomarkers that kind of predict the risk of high-risk IPMNs or the risk of progression to cancer. I'm not sure if there was any analyses incorporating those biomarkers in addition to the cyst size and stability, and potentially using that as an additional tool, determine potentially even stopping earlier.
Great point, Jack. I love this topic. And don't make me wrong. I mean, the fact that this analysis didn't take into account biomarkers is basically, because we still do not have a biomarker that we can incorporate in a clinical practice. So we really wanted to provide answers with the weapons, with the tools we have now. But biomarkers are here. So I just don't want to, leave the last slide, with a future perspective by saying, yeah, one day, no. It's happening, okay? It's happening. It's just a matter of like refining reliability. And of course, once again, the matter of the cost, okay? Because we really need to have a test which is not just reliable, but also fairly cheap. But that's the only way, Jack, that we will be able next future, not only to define who is a surgical candidate and who is not, but also by defining the trajectory, of the evolution of a cyst, who is warranted for a follow-up and who is not at baseline. So even I would say there is a concept in the surgery for IPMN, which is the ideal goal for surgery is high-grade dysplasia. But that is, of course, because what we have now is just trying to depict, based on this feature, who is progressing, towards all the step, towards high-grade dysplasia, and we want to operate him on before the stage of invasive cancer. But what about the biomarkers telling us that this cyst will eventually evolve into invasive cancer? So in this way, our ideal target for surgery could also be low-grade dysplasia. So this is really revolutionary. So you really touched, I think, the point, which will change everything. It's a matter of, I think, waiting another couple of years because there are still issues, regarding reliability and of course, again, cost regarding these new tools.
Excellent. Thank you. That's amazing. Michelle, are you on the line? And if not, I can.
Yes, I am.
Excellent. Hi, Michelle.
Hi. So thank you very much for your time. And my question is more for a clinical application, since even though we know this particular type of lesions may have a low risk of developing into malignant lesions. However, anything relating to pancreas can really trigger anxiety in patients, especially with family history. So what would be your word choice or your way of counseling patients who are with high functional status that surgery may still remain an option, as well as people who are having family history to actually use this study?
That's another great point, and so I really want to thank you. Because you let me specify first of all that so far we don't have enough evidence to avoid surveillance at baseline in anyone. So I just want to again specify that to date we start surveillance in every cyst, only in those who are not fit for surgery. So that means that by definition they would never make it to the operating room. Then in these cases, we avoid doing surveillance, but other than that, they all start surveillance program. So after 5 years, well, my experience running a cyst clinic is that you get to know the patient. So basically, it takes time. It's tough, but it's truly, I would say, an outpatient clinic that tells you a lot about the person you have in front. I think it's important to share what is known, but also what is not known about a cyst, to gain credibility, and to have a positive impact on this person. And then after 5 years, to explain that then the risk is not higher than anyone else without a cyst in the pancreas, again, could be tough, but I think it's something that we must do. We need to have, I think we have the responsibility, to tackle this as pancreatologist, I like to define myself as someone who deals with the pancreas. In this case, maybe pancreatologist, because we're now dealing with a cyst in the pancreas. And it's difficult because I mean, now that I started, to tackle the issue of follow-up discontinuation, some of the patients might feel, oh my God, you're abandoning me. What's going to happen to me? And then in this case, you should be really, really clear-cut in saying that what we've been doing so far, after 5 years, is not really protecting someone from cancer. And it just, increases the level of anxiety, and even without talking about the cost, because I think that, for a patient, the perspective of like saving costs is not really the right one, but we really need to, to feel this responsibility to save examinations that are not really, going anywhere. It's sort of like, preventive medicine or something. And once again, we're not saying that we shouldn't follow BD-IPMN, but that we need to stop surveillance after 5 years in selected cases. That's probably something that needs to be underlined, but it takes time. A cyst clinic is really, is really difficult sometimes.
I share that difficulty in counseling patients and completely can relate. It's quite challenging to explain to a patient, especially with any conversation regarding cost. So it's not an easy conversation, but a super important topic. Michelle, you had another question?
Yeah, so thank you very much for the explanation. So I guess my follow-up question would be like, what made you choose 5 years versus like a stepwise kind of like stopping of the surveillance? Like, what goes into the 5 years that makes you feel confident?
Well, that's another great question, but sometimes you need to choose a number or a time point, because it's already in the eyes and in the ears of the clinician. So 5 years, I think it was a major policy of the original AGA guidelines. And I was in the US when they were released, and I remember the storm, in the main centers, because this was really a very, I would say, contrasting policy. David pointed this out. So we really wanted to stay on that same threshold. It sounded reasonable. And then we had also studies on models. There is now a new study from our Dutch colleagues that, again, tried to model, the evolution timing of different stages of dysplasia. And once again, this 5 years comes back as the time that a cyst, usually when it's high grade, tends to evolve into invasive cancer. So it's a number that it's really related to the IPMN. But if you ask me whether it came from a specific, statistical system, or if we chose it because it was already used in a clinical practice, basically it's the second reason.
Well, we can blame Dr. Moietti, who has joined us since the conference started, as he was one of the primary authors of the AGA guideline. And Paul, can you comment where 5 years came from, if you recall?
Giovanni expressed it very well. With all respect to pancreatic researchers, the data that we were dealing with in 2014, the time we were doing these guidelines, was not great. So in the absence of great data, you do have to go on your best guess based on the limited case series that you have. Where the follow-up was usually at most 5 years, and where nothing seemed to be happening in certain groups of individuals. But also, if you look at Barrett's surveillance, if you look at colonoscopy after a polyp removal, a low-risk polyp removal, they're all 5 years. So it seemed a reasonable timescale to use, but it's not based on high-quality evidence, but the contrary. And in case you feel I'm criticizing pancreatic researchers too much, I can switch any disease and I'd be saying a similar thing.
But if I can comment on that, Paul, I mean, well, we didn't know each other at that time, but to me at that time, it sounded like sort of a perspective. It was more philosophical, I think, from the AGA towards guidelines that at that time were mainly drafted by surgeons. And so the evidence at that time mainly came from surgical series, And once again, I mean, it was based on rates of malignancy rather than on an actual risk. So now that we have evidence coming from long-term observational series, we know that the biology is completely different. So it's truly a matter of perspective. And now probably we can use those rates of malignancy in resected IPMN as a surrogate of how good the selection was, but not actually about the risk of a given lesion to be in a cancer. We also have the issue of misdiagnosis, for example. So many entities, we probably think they're IPMN, indeed they might be something else. So probably if I got it right, that original policy was somehow, reshaping, the landscape at that time to say, well, probably we're overestimating the actual risk of this lesion to evolve into a cancer.
Thank you.
Absolutely right. We don't have the answers either. We're taking a different perspective on how you could interpret the evidence.
That's fantastic. Wonderful discussion. One of our fellows has a question. Sandy, do you have microphone access? I think you had issues a minute ago. And if you don't, I can ask your question. Okay. So patients who had stable branch duct IPMNs less than 15 millimeters had no increased risk of developing pancreatic cancer compared with the general population and can theoretically discontinue surveillance. How has this translated over to clinical practice?
Oh, so this comes the critical part. So, I mean, honestly speaking, I mean, right now, this becomes as a very critical policy because we know that at 65 years old, age is a relatively, young patient. Still, we're now talking about those entity below 15 millimeters. So just a word of caution. I mean, we know from the evidence that many of these entities probably are not even a branch duct IPMN. They can just be, ectasia in the duct. But I would be more reluctant here to then promoting follow-up discontinuation. We included this cluster of patients because we really wanted to provide an impact in terms of cost and on a population that is still clearly a surgical candidate. Because, some of the reviewers raised the issue that probably, to deal with people beyond the age of 75, probably, would pertain to someone who's not a truly surgical candidate, which I don't think is the case because we perform pancreatic surgery also above the year of 80, if a patient is fit. So that policy was actually put in the paper to impact more, on wider, populations. But it has to be validated in stronger cohorts. So I would be a little bit more, in this case, reluctant to dealing with follow-up discontinuation.
Thank you, Giovanni. Jack, who's read through all of the supplementary data and wanted to ask a question regarding that.
I noticed that looking through the supplementary data where a lot of your data was pulled, I noticed that the centers in the U.S. had much higher surgical rates as compared to Europe. Any specific reason why that may be, or?
No. Honestly, I'm always surprised when these epidemiological data they pop out and they actually express these differences, because to me it doesn't really make any sense. So, but what makes the paper strong is that we also run a different analysis with a validation set in the Eastern population compared to a training in the Western, and still the model is valid. So I don't want to comment any further on that, because as long as we don't have data from the genetics and the molecular data, it's, I think, really speculative, So I don't really think that there is, a different biology of the disease, depending on country. But still, I mean, to my knowledge, we're very far away from having solid answers, but that should come from biomarkers and not from, studies like this.
Sorry, I can interject here. I think I do know the answer because I do have a little bit of a health economics background. And health economists tell you that anywhere where there is a very remunerative fee-for-service structure, you will do more as a surgeon. It applies to removing gallbladders. It applies to hysterectomies or anything else. Basically, if you incentivize people to do things by paying them, they will do more of them. Add on top of that a litigious system where if you don't do something, you are sued. This magnifies the problem. And the US system exemplifies that approach. And that's probably why you're getting a difference, not biology, but more the system which they are in, that has perverse incentives to not necessarily do what is right for the patient. But I'm not saying this, the doctors are behaving badly, just within the system they're in, everything is pushing towards doing surgery. Whereas in Europe, for example, where I originally trained, particularly in the UK, there is no such incentive, either on the legal side or the way you're paid side. And obviously Italy and others are in between that, but still, I think that concept still remains, because the US is the epitome of fee-for-service and legal profession getting involved in medicine, probably more than any other country.
Really interesting conversation, provocative question and answers, and I had wondered if maybe there was a different biology in the surgeons as well between across the pond, but might not be the case. Zank, you have a question regarding family history?
Yeah, so I was wondering if you had taken into account like a positive family history and if that affects like the recommended cutoff interval for stopping surveillance.
It's definitely a factor in the equation. I mean, I want to underline that still, I mean, we're looking forward to additional data from the big registries that we have on familial and pancreatic cancer. What we know is that the screening on these individuals is actually worth it, because we know that we have higher rates of newly detected cysts. So this probably could serve as a way to, you know, correct and to even personalize better the follow-up. Because we have, again, reports that the family history plays actually a role not only in the crude incidence of cysts, but also in the risk of these cysts to basically, you know, evolve into cancers. But again, I would be very cautious in providing with the message that a family history of pancreatic cancer is strongly associated with the development of pancreatic cancer from a cyst. In this case, I think the follow-up, once we're truly dealing with a family history positive pancreatic cancer, is needs to focus on the entire organ and not just on the target cyst, because we know that we don't have just the issue of invasive cancer developing from a cyst, but also the occurrence of concomitant TDAC, which is a complete different story, and it's probably something we really need to explore more, once again, thanks to the genetics. So that's, I think, another very relevant topic that needs further exploration in the next years.
Yeah, the population actually that is probably at greater risk, because it's not unusual, of course, to find someone who has a family history of pancreatic cancer, but there's a lot of emerging data that concurrent mutation, for example, with BRCA1 or 2, which is fairly common, particularly you know, in the Northeast United States, patients with pancreatic cyst and those mutations are at higher risk in general for pancreatic cancer simply because of the mutation, but the cysts themselves appear to be even more problematic. So again, it's probably premature to say I'm going to operate on someone just because they have a cyst and this mutation, but certainly that's a population where, knowing what we know, I at least would be very uncomfortable stopping surveillance, even if it was 15 millimeters and somebody was 70. For example.
Thank you. Zank, you had a follow-up question regarding cyst growth?
Yeah, the other question was, did you find if like the rate of the cyst growth within the first 5 years of surveillance really affected the rate of growth, like the chances of developing worrisome feature or high-risk stigmata after the 5-year cutoff?
So thank you for the question. As you know, a growing cyst is actually a very important worrisome feature. So of course, those entity, once this factor occurred within 5 years, were out of the outside the trivial population. So of course, those individuals would not stop surveillance. Still, I was a little bit disappointed by the latest evidence regarding cyst growth, because I really put a lot of attention in this factor, but still this worrisome feature did improve to be as a standalone significant risk factor for pancreatic cancer. So what the guidelines now said about cyst growth is to tighten the follow-up or even to go for EUS. Unfortunately, if there is no target for our endoscopist, probably this examination does not provide that many answers as the one we would look for. So right now, if a cyst is growing and it's a fast-growing cyst, probably the wiser policy is to strengthen the follow-up, to make it tighter, and to remain on a 6-month basis to see whether something is happening or whether there is a sort of a misdiagnosis. You have to always to keep in mind that something that is enlarging, it might be because there is an obstruction, and so a solid component is growing. So it's definitely a worrisome feature. Again, more studies are needed, but a growing cyst will never fall into the trivial definition. So we won't actually stop surveillance in these cases.
Great. Thank you for that answer, and thank you for answering all of our fellows' questions. There were probably 24 more questions that they had prepared for you, but we set it to stop at 10 questions. So really, thank you for that.
Thank you. You guys were great. We have a couple minutes left, so let me take the prerogative of asking Giovanni, as the only surgeon with 20 non-surgeons basically staring at him. You made a somewhat provocative statement somewhere 20 minutes ago or so that the optimal surgical target was high-grade dysplasia. I would ask you to defend why you think that's true, because if you operate on someone, you find high-grade dysplasia, and even in your expert hands, there's a complication. The patient's going to say, was this surgery worth it? I didn't have cancer, but I do have these complications. So what do you know about the natural history of high-grade dysplasia in pancreatic cysts that perhaps some of us don't, that makes it an optimal target, to use your words?
David, you're opening
I'm going to give you the easy one at the end.
No. I mean, you open a Pandora box, so I'm sorry to say that with my Italian accent, now it will take 1 hour and a half to answer to this question. Sorry. You know, they would like to be Baroque. No. So you want me to defend this policy, but to defend this policy, as a matter of fact, I don't think that is something that I would say is the right way to do. You need to go back to the original surgical data. Okay, so the original surgical data, biased ones, basically simplify, the outcome, which is the path reports, in either operating too early, namely low-grade dysplasia, or too late, invasive cancer. So with this in mind, high-grade dysplasia has been historically seen as the target for surgery, okay, because the evolution has made it to this step. But by definition, we won't have any nodal positivity nor theoretically risk for recurrence. But I tell you a story. So I know case reports, they don't make the history of the literature, but there's a very interesting one. We did an operation, actually, I wasn't there in Italy, on a lady back in the late 90s. At that time, as I'm the only surgeon, I will tell you that we now stay close to the vessel, so we take out all the tissue around them, but at that time, that was not the case. So it was an operation for a BD-IPMN of low grade, but a small piece of it remained attached to the vessel. And what happened at that time was that the small piece of IPMN grew year after year, decade after decade, developing a solid component, and the CA 90.9 went high. So long story short, we operated on this lady 25 years after. And that actually provided us the unique opportunity to see the evolution from low-grade dysplasia, 1997, to, again, it was low-grade dysplasia in the same cyst. So this tells us, even if it's only a case report, how few knowledge we have about the biology. There is one paper in gastroenterology from a Dutch group that now is assessing, thanks to a model, the timing, of this dysplasia to evolve. And high-grade dysplasia for the cyst that you assume that will become invasive cancer is more than 5 years. So I completely echo your comment. Why is that high-grade dysplasia the right timing for an operation? Probably is the best we can do. But then when you deal with the complication, I would rather keep my high-grade dysplasia rather than having an awful pancreatic fistula, with a 3 months staying in the ICU. So it's a true dilemma. I think that the policies that we had back in the day were more, let's say, damage control. So we really wanted to be very proactive about this cyst. But now the more we know about the biology, I was mentioning that before, the more we can change this target into any type of dysplasia, but if there is a molecular test telling us that the evolution will take place. Then you have time for counseling. You don't have to worry up in the operating room, but then you have the right surgical candidates regardless of the grade of dysplasia of the cyst.
Great, thank you. And so thank you very much, Giovanni. It's a great paper and it will have impact, no doubt. Thank you very much to the whole Northwell team. You did a fantastic job. We look forward to having more journal clubs like this one in the future.
Thank you. This was fantastic. Thanks to the AGA as well.
Ciao.
Bye-bye, everybody.